about the virus. We didn't know how to protect us. We don't know enough yet, but we know better. So I'm going to focus a little bit in what we do in laparoscopy and how to do some of our closures safety. So one of the components is that we know that the coronavirus will spread to aerosolization. And most of the aerosolization in laparoscopy came from energy and from the CO2 who came from inside either the abdomen or the chest of the patient. So we need to prevent to be exposed to that. So all the societies and all the groups and scientists are giving us some things to do related to that. So let's see first what we were using this device before this happened. So this trocar closure device, it gives you an automatic closure system even before you start the procedure. Because once you put the CO2 inside, you create the pneumo. When you put the trocar, you already place the stitches then. Then when you finish, the stitches are already in place just to be closed. So you are not going to require insufflation to close at the end of the procedure, and that's one of the recommendations that we have now to do this very safe. But also it captures very good amount of tissue similar in both sides without using any other passers. We used to use some needles, some passers. In order to do that, you need to remove your trocar under the insufflation and then put the new passer, or you need to start to puke with needles, to pipe with needles and see what you see. So this is the common way we use to close the ports. There is the manual closing with suture. It is the most common for our obesity surgery patients, but also for all the obese patients that we do other procedures like gallbladders, splenectomy, pancreas, etc. It's very time consuming to close the trocar sites. It requires some skill, takes some time, and you usually do it after the procedure, and sometimes you require visualization and insufflation. Then closure devices start to come, and that's an important thing because it helps us a lot. In the past, some of us never close a trocar site. Either we do very tangential incisions or placement of our trocars, but now more and more with hernia sites are coming, probably not yet, but it will be maybe standard of care to do that. So the closure device required two things that they were okay for us before this virus and this problem that we have now. You need insufflation and visualization are required to use those closure devices. The results can be inconsistent, and we all know when we put some of our needles like this, when we go through special passers, when we put just a needle close to our trocars, you don't get the specific the tissue you're looking for. And sometimes you were happy, sometimes you don't. So they are inconsistent. Also, you can cause trauma. You put big needles, you can puncture the small bowel, any other organ. And also, you do this at the end of the procedure. This was not a problem again in the past. Because you remove your trocar, you put the passer, and then you put the needles. Now, if you need to remove the trocar, if you need to change to a specific passer, you ended up having a lot of the CO2 with the fumes from energy devices that we use from the patient abdomen or chest to the operation room. And that's one of the risks we are trying to prevent. As you know, we're using filters, smoke evacuators. We do everything during surgery not to have contact of our health personnel inside the OR with this CO2. And now at the end, we need to close, and now we're going to have contact. So that's not what we want. So when you closure with this trocar closure device, once you place the trocar, you already have in place two sutures in both sides, and they have anchors in both sides. Every anchor and the suture, they are absorbable. So when you finish the procedure, you just need to close them, and they will absorb from 3 to 6 months later. Also, this is the typical closure that you have like a full loop knot. Here you have the half loop knot, but you have the anchors there. So when you close at the end of the procedure, you will need insufflation. Here you don't. You need direct visualization. Here you don't. So also, if you understand well how are the loop system versus the half loop knots, you create much more tension. If you, I mean, you try better the tension with the half loop knot because it's a little bit higher, 25% more. Today, all the closure devices that we use at the end of the procedure can toggle a little bit in the port side, and that will give you a different amount of tissue that you can capture. So, and again, it's some inconsistency that we were trying to prevent. And that's why we're using the closure device before even this happened. Now we have more reason to use it. The tissue passer is sharp, and again, it can cause some damage or trauma. So I want to show you this short video of how the troclos work. So as you saw there, and that's important for me to mention before, is that for demonstration, we kept the camera to show you how we tied inside. Now with all the problems that we're gonna have with the fumes, we don't need to keep the fumes. We can take everything, all the CO2 out, and the characteristic is still the same. Absorbable sutures that are like Vicryl, absorbable anchors with PLGA, and the tip is bladeless. So for me, and this is my own experience, I usually place first a 5mm trocar with a camera because I like to see the entrance of this trocar, because I want to make sure I put it correctly, and then I want to make sure that I deploy the suture and the anchors correctly. Once I do that, then you continue with the operation, and then it doesn't matter how long it takes, it doesn't matter how tired you are at the end, it doesn't matter how obese is the patient, it's gonna work. Why became this important now? We knew before even all this was published in 2019, that with the smoke we get in surgery, you have different things that gonna go through the people who works in the OR. You have some chemicals, you have some biologics, malignant cells like bacteria, viruses, that can cause diseases and problems, some chemicals that will cause some symptoms and problems in ourselves, and then even they can deposit in some of our organs that can cause some problems, specifically in the respiratory tree. But today, there are 3 different risks in surgery. While you insufflate the patient, while you remove the specimen, and at the end, when you deflate the patient, and when you close the trocar holes. So we learned during this pandemic, and this is some of the guidelines from any society, including ourselves, that the patients with this virus that they cannot go to laparoscopy are patients that their own respiratory system doesn't allow to laparoscopy to happen. Otherwise, if you can do the procedure by laparoscopy and not open, you're doing better. Because in the abdomen space, in the chest contained space, you can control better all the fume from energy and all the environment of the OR. The pressure has to be a little bit lower if you are concerned about the virus. And then trocars, incisions, and leaks are very important. We now are marking with the head of the trocar in the skin exactly with a marker the size of the trocar. In the past, I do a little bit wider incision the first one. I don't want any pressure when I put my first trocar. Now, I measure exactly the size of the 12 and 5 millimeter, and I'm gonna make sure that I don't have a lot of no movements or leaks on the side of my trocar. That's one of the other changes we have. Then also we need to use some filters and smoke evacuators. I think this is gonna become mandatory for the future. Even when we have vaccinations and everything for the coronavirus, filter and smoke evacuators will be mandatory, because then we can control not only that cavity CO2 and fumes, but also we can remove them all the way from the OR to special containers that they're gonna be disposed. So that's something interesting, and this is something that is controversial today, but there are some people suggesting that we use only disposable instruments, and when we finish, we dispose of them. And every time you put inside an instrument and take it out, you need to do some quick sterilization inside because maybe that will be a problem. So when we review the SAGES guidelines for COVIDian, we find some practical measurement for laparoscopy, and this is the 3 important that I found. Incision for pores should be as small as possible, but and again, small, if you need to push a lot, that's a risky for the organs inside the abdomen or the chest. So what we do again, we measure with the head of the trocar, sorry, with the head, not with a circle at the end of the trocar, so we measure exactly the specific size of every incision. Second, the CO2 insufflation should be kept a minimum, but minimum for me means that you still doing your operation comfortable and you seeing everything you want to see. Also, will be mandatory to use any of the ultrafiltration. I found myself the better the smoke evacuators, but there are many, and they are cheap, but they must be used. And also, all the pneumo should be safely evacuated, and trocar removal, specimen extraction, or even if you convert to open. If you have to convert to open, you need to make sure also that all that fumes go to that container. So if you already have the closure suture before you start the procedure, then at the end, you're not gonna require insufflation or visualization to close it. So we find now a new use for the device that was not necessarily appealing then, because all of us remove all the fumes, we open the trocars, and we let all the fumes go out, and then we deflate the patient. Now we cannot do that. So if I want to close my trocar holes at the end, this provides a very safe environment to do that for all the healthcare workers that they will be on the OR. And also, there are a couple of papers that will tell you that maybe the pain will be a little bit less because there is less tension. So if you follow most of the new SAGES, European Association, other international guidance societies, all pneumoperitoneal should be evacuated before closure, trocar removal, specimen extraction, or conversion to open. So this is part of the solution for us now. The troc close, that is a half loop system, so create less tissue tension, but also because the anchors and the suture are deploying at the beginning, they won't cause any harm, and you're ready to close when you finish. The good thing is, while you deploy them, you have your camera in, you also can confirm that they are placed, and then you don't need to do anything else when you finish. I will say that even not everybody close the trocar holes. I think it will become more normal to do it now. And this will be a lot of help for us. And I'm not aware of any other device that does this. So following this response to the crisis, in my understanding, is the only commercially available, because I saw some prototypes, but it's the only commercially available device that will accommodate to that guidance. Yes, you can remove, deflate the patient, suture by hand, that's acceptable. It's very difficult for obese patients and morbidly obese surgery, but it can happen. But if I already put them at the beginning, it doesn't matter if my surgery took 1 hour, 2 hours, 4 hours. When I finish, I just deflate the patient safely, and then I just tie the sutures and I finish the case. This paper that I recommend that you take a look if you are interested is published by the group of David Hassan. Is the use of the novel integrated port closure system. It's a multi-center study, and it was published April 25, 2020. I'm sorry, I'm very late with the references. So it's like, I'm 10 days late or 15. So what they conclude in this paper is that it was very easy to use. And they create a score of how good was the deployment of the anchors and how easy it was to use. And up to 1 year follow-up. And we know the hernias can happen anytime, but we also know from laparoscopy that a lot of our hernia port sites are in the first year. So they have 0 port site hernias in bariatric procedures with 1 year follow-up, specifically in bariatric procedures. That way, sometimes we are more concerned. The good news also is because one of the suggestions we did to the company is that we need the 15 millimeter port, because I don't do that, but some people use staplers with 15 millimeters, so you need something for 15. This goes up to 12. Either that you can close on 15, but sometimes you need to add an extra suture. Also, the necessity to have the optic close, so then you can have it. They're working on that, but more importantly, a disposable port for robotic surgery. And this is very interesting to me, because if we're gonna start to be scared now of what we can get as health providers inside the OR from the CO2 and from the energy devices and from aerosolization, maybe in the future a surgeon will be sitting in his robot covered with this plastic or glass like you see now in the supermarket, 6 feet away from the patient, so he won't get any contamination himself. So having a device like this for robotic surgery, I think, will be mandatory in the future. So they have been working in all of that, so we cannot wait to try them when they have them. But so far, I think this helps us a lot at the end of surgery to have some better relaxing and better protection for our health providers inside the OR. Thank you very much, guys. If there is any questions that you have, I see there is question. Oh, just hi. Anybody has any question, you can write it in the chat. I don't know how many of you are familiar with you. Welcome from Turkey, Halil. And welcome everybody. I will wait for some questions if you have some. You have any question, Dennis?
No, I want to just say wonderful presentation and excellent comprehensive information on, we all now have a new normal, which the new normal indicates that we are all treating all patients as if they are COVID. So that does change our new normal. I'd like to ask everybody who is online to please follow Gordian Surgical on our LinkedIn. And of course, if anybody would like to have any of the papers that Dr. Zundel talked about, I'm more than happy to send them to you, the new clinical study. and following us on LinkedIn, you'll also be apprised of the new robotic kits that will be attachable to the reposable arms of the robots. So this is an important new product that I know that there's a lot of anticipation for this. So thank you, everyone. Thank you, Dr.
That question from Luciano Inocenti, okay? Have you some tips and tricks to use correctly through close? Hi, Luciano. Luciano, sorry. Yes, I think that even that is very easy to use. I will say for me, what is important is look into the direction of the incision. Then the trocar, you need to make sure go in the same direction of the incision. Then you position the loops and the anchors where you want them to be. Because if you put it in the other way, then the loops will be on the side of the incision and you want them opposite one to another. That's the trick for me. So what I do is, even they tell you that the anchors are this, I always look at the trocar, look where the anchors are, look at my incision, and then I make sure that one anchor is here, the other is here, if my incision is like that. Because if you put one here, another here, then you are gonna put it in the wrong way. That will be one of that one. Somebody's asking for trocar 15. I don't think his name is Galaxy, but I will answer. And he's asking in Spanish, so probably say, so yes, they're working for the 15. I think we discussed it for a year and a half now, that a 15 will need for some people, and they're working on that, and they're very close to have it. Thank you, Halil, to you for attending. That's the other comment of question. Surendra, how are you, my friend? So I hope you're in India taking care of yourself. If you had any problems at all, you feel the suture is fine, it's enough. I think the suture is fine and it's enough, and also the anchors. The only problem I see, Surendra, is if you don't position well your anchors. I think that's the secret. That's the question from Luciano was very important. You need to make sure that your anchors are one opposite to the other one in the proper side of the incision. With that, you won't see any problem. The other good thing is you can check since the beginning, because I do this under camera direction. So I see it well, but the tension I get from the suture is pretty good, Surendra. Good. Patrick Zoom, could use combined with the endo JAI? Yes, you can use it with any of the other one. So far, the only thing you cannot use is for 15 millimeters. So if you have the black, for example, you cannot use it because they use 15. Otherwise, you can use any of the other ones. But by the way, now, remember, some people take out the trocar, put the circular staplers through the incision. All that is gonna change. So I'm gonna take the advantage now to tell Dennis and the group from Gordian that maybe it will be amazing to work in a 15 that allow the circular stapler go through that one, or a bigger one, 21, because nobody will put now circular staplers to the incision with the risk of this contamination. Johanna Romero, what is the size of the suture? Dennis, what is the size of the suture? Is 2.0 or 2.0?
Yep, sorry, it's a 0.
Oh, 0. Johanna is 0. I mean, for me, it felt very strong, so I didn't mind. It looked very, so 0 is even better. I see 2 more questions probably. How many millimeters of the incision the anchors are, and what is the width of the anchors? I'm not sure what is the width of the anchors. Probably Dennis will tell you that, but it's very wide. And usually there are like half a centimeter from the incision. You know what is the width of the anchors?
I have to get the exact width. I can respond when I send everybody an email thanking them. I will put that in there.
Thank you. Professor Matthias Fobi, Mel, I'm glad to see you here and you are doing well. He's asking Dennis if this is available for use in India.
Yes.
Yes, Mel. So
it is CE marked and available.
So Dennis will be in contact with you to send you the info for India. Antonio from Spain, thank you. I think 50 millimeter is a trial if you are using black cartridges. Exactly. So I think, gracias, Antonio. So yes, we think it's important to do that. And I think Antonio think that trial will be important when the 15 is ready. And I think Antonio uses it very often, so maybe they can use his site for this trial too. Okay, I don't see more questions now. You see more?
I just verified the width of the anchor is 3 millimeters.
Okay, Surendra, did you ever need a much longer trocar in any of your bariatric patients? I'm a very weird person, Surendra. When I did my BMIs of 90, 89, I used longer trocars. And I had much more problem with the longer trocar. I like long instrument, longer trocars I don't like. I tell you why. Because when you have the depth of this incision to the abdominal wall, even if you put a longer trocar, the strength you have to do to work, I broke instruments, I broke trocars. So what we learn to do is I do a bigger incision on the skin. So when I put my normal trocar, the trocar go all the way in to the abdomen. And the head is very close to the muscle. So the incision in the skin is bigger. But remember, the muscle of this patient is very tiny because they're malnourished. So I put the whole head of the trocar inside the incision, and I never use longer one because it caused me more problems to do this patient. So incisions are not that important in the skin. I will close them, but in these 90s, 85 BMIs, 100 BMIs, I just put the whole trocar inside the skin, and it's better for me. There is another comment or question. Less tension with better tissue approximation leads to better outcome for patient and surgeons. I totally agree with that one. Thank you, Surendra. Yes, that's I'm just fault. I've been doing this for a long time, so I learned that trick long time ago, and I'm happy with that. I don't put longer trocars anymore. That's why they don't produce it much anymore, because they are not the solution. The solution is bigger incisions in the skin. So as you heard, Dennis, and whoever is listening from Gordian, everybody thinks we need a 15. I am the one pushing for the robotic one. And Luciano asking, do you think that it's important to lift, pull up, throw close trocar before firing the anchor? Yes. I think it's important because then you are, for two reasons, Luciano. The first one is, if you see the tip looks like an arrow. So when you push him back, you see perfect. Even sometimes I rotate a little bit against the muscle and the peritoneum to see exactly where the anchors are going to be deployed. I like that tension, and it gives me more reliability in where they're going to be fired. And I think it's the recommendation from the company. So I follow that recommendation. But for me, it's for location, location, location. Okay, guys. Any other questions? So if there's no more question, I'm going to thank Dan, Tzvi, Leo, everybody from Gordian for the opportunity to discuss that. I don't think you're lucky that now we're going to need more than ever. I think you'll be thinking all the time in prevent the work at the end of surgery. So now preventing the work at the end of surgery with safe closure will be also preventing the CO2 going out to the OR. And this is one of the, if not the only solution we have now, and manual closure. So thank you, guys. Surendra, do you think there could be reusable cannulas in future with only disposable tracker as future? Yes, I discussed this with them. I don't think it's the solution. You know what they're thinking? Maybe Dennis want to explain this a little bit. They're thinking how to use a same trocar with different sutures. Dennis, you want to talk that to Professor Ugale?
Certainly, certainly. So what we have at least now is a secondary cannula, which uses the same obturator. So if there are more than one port bigger than 10 that you want to deploy the anchors, then not buying a complete kit and having a secondary cannula for just the purpose of deploying an extra set of anchors.
Yeah, you are on the point, Surendra. We think that in order to have this in all the 12 trocars, or 15 and 12, they cannot be that expensive that you need to use a new set. So that's the answer, and then that will help a lot. And that will allow us to use more of this one and not close one and the other one no, because that won't solve the problem.
And we will have a 15, by the way, everyone. We're working on it now, and that will be available in short order.
So now you know, Dennis, that Antonio Torres from Spain want to try some before. So,
absolutely.
So he's
and we will make that happen.
Perfect. Okay, guys. So we good. You want to say something else, Dennis, at the end?
Just thank you very much, Doctor. It was a very comprehensive webinar. Thank you all the participants that took time out of your day to join us here. And please follow us on LinkedIn. If there's any private messages for me, I will send an email that has my contact, as well as my colleagues overseas that can help our overseas participants. So thank you all. Be safe and be well.
Thank you very much again. Goodbye, guys. Whatever time, for some is night, for some is early morning, for some is late afternoon. So everybody will take care.
Be well.
Be well.
Thank you, Dr. Zundel.
Thank you, Dennis.